Good morning. It's a pleasure to present here. Good morning, everybody. So, I have an interesting case to present, which is hyponatremia related to megestrol use. I have my co author, Dr. Isaac, and my preceptor, Dr. Anjum, who helped me with this presentation. So, um, this is a 60-year-old female that presented with shortness of breath. She also reported some intermittent weakness, confusion for past 1 week. Here are her vitals. Temperature, she was afebrile, pulse 75, respiratory rate of 14, blood pressure 130 over 78, and she was saturating around 95, 96% on 3-liter nasal cannula. Physical examination initially was consistent with a poorly nourished female. She had a BMI of around like 18. She was in mild respiratory distress, having bilateral extensive expiratory wheezes. She was intermittently confused and had generalized weakness, but no pertinent abdominal or cardiovascular findings on examination. So the initial pertinent labs that were significant for leukocytosis of 14.2, sodium was really low of 117 and chloride of 75. So when we searched some past records, the patient had been chronically hyponatremic, running in 120s for the past few visits, and especially in the past 2 years when she came in our hospital. The urine osmolality was 224 and urine sodium was 49. So initially it looked like this could be some SIADH going on. However, on further investigation, we did some other labs like morning cortisol levels, TSH levels, free T3 levels, and they were all reduced. We did a co-centropin test stimulation that demonstrated cortisol levels of 14.2 at the half hour, indicating that there is adrenal insufficiency, the cutoff being 18. So if it's less than 18, there is some adrenal and secondary adrenal insufficiency going on. The chest X-ray that we did demonstrated consistent with COPD. So this patient was concomitantly going into COPD exacerbation as well. So we started initially with a normal saline and serum sodium levels started to improve. She was also started on steroids for the COPD exacerbation, and hence that's why the sodium was slowly getting improved as well. The medication review revealed patient had been using megestrol acetate 40 milligram BID for the last 5 years for her chronic malnourishment to increase her appetite. So when we found that, we immediately did some literature review, and we found that there is some association between megestrol and the chronic HPA axis suppression causing hyponatremia. So other concerns for SIADH was ruled out because the patient improved with fluids and steroids and discontinuation of megestrol immediately. So after the discontinuation of megestrol on two different occasions after the patient were discharged, patient sodium were found to be in 136, 137, and it was pretty normal. And that's the best that had been in the past 2 to 3 years that we have seen. So the discussion part of this presentation would be our patient highlights a rarely thought of clinical association between megestrol and hyponatremia. Very few cases have been reported where megestrol actually causes hyponatremia due to chronic HPA axis suppression. There have been some literature where megestrol causes HPA axis suppression, but causing hyponatremia with it, it's a rare association. So we hereby suggest monitoring of basic metabolic profile in patients taking megestrol as an outpatient. Conclusion wise, we should monitor patients for signs and symptoms of hyponatremia like weakness, confusion, and after initiating treatment, we should cautiously start these patients on megestrol. Also, patients who have had history of SIADH and HPA axis suppression, we should not start megestrol and be cautious in the initiation of this drug. If symptoms concerning for acute hyponatremia occur, like confusion, like neurological symptoms, patient should be immediately hospitalized. Uh, so the learning objective from this case would be recognizing megestrol acetate as a potential risk factor for causing hyponatremia and encourage further investigations for megestrol-induced hyponatremia secondary to HPA axis suppression and find its actual true incidence. Thank you.
Thank you. Are there any questions at this moment? I did have a question. So I saw your urine osmolality was 224. Did you rule out some other differential diagnoses, maybe diuretics, nutrition, things like that?
Yes. We ruled out a lot of differentials. We ruled out the patient was not on any diuretics as an outpatient. I mean, she didn't take any diuretics at home. She was chronically malnourished, but she had been hyponatremic for some time. I mean, for the past 2 years, she was chronically hyponatremic, and sudden increase in the sodium, even on discharge, in the next 1 month, the sodium reached 137. So, I mean, there is direct relation that stopping that drug and giving some stress dose steroids helped her. So
Okay, wonderful. So you stopped the drug and you gave her some steroids. Is she doing much better now?
yes, she's doing much better. So she visited as an outpatient twice when we saw her, and she was like, her sodium was like better controlled, and she was doing much better. No symptoms of weakness or any of those neurological symptoms. She was chronically weak for like years. So I think the hyponatremia was kind of playing a role in that.
Wow, awesome, great presentation. Any final questions for Dr. Vyas? All right, thank you.